So please confirm that you can hear me clearly using the chat box kindly. Okay, so our first question, this set of questions are from the MCQ makeup paper for last year. So you can as well go through other sections. The ones that I've selected are for hematology only. The first question is, clinical features seen in multiple myeloma include all the following except. Multiple myeloma is a malignant plasma cell dyscrasia characterized by uncontrolled proliferation and the diffuse infiltration of monoclonal plasma cells in the bone marrow. So what you need to focus on so that you can be able to tell the clinical features is this part where it says, diffuse infiltration of monoclonal plasma cells in the bone marrow. So when there's diffuse infiltration, it means that the function of the bone marrow of producing red blood cells, white blood cells, and platelets will be dysfunctional, or it will be deranged. So what do you expect? You expect that there'll be anemia, and you accept generally a pancytopenia. There'll be anemia, there'll be thrombocytopenia, and there'll be leukopenia. So from this, you already have C and you have D, because when there's leukopenia, there'll be recurrent, chronic, and resolving infections. And then as for hyperuricemia, when the cells are infiltrating the bone marrow, malignant cells tend to proliferate fast, and they also die fast as well. So when they die and they're being, what's the right word? Sorry. When the cell turnover is high, then it means that the breakdown is also high, and it leads to high uric acid levels, causing hyperuricemia. And then as for hypocalcemia, we don't expect multiple myeloma to cause hypocalcemia because multiple myeloma, first of all, it signals interleukin-6, which increases the osteoclast function, where it increases bone resorption, and therefore the calcium is released from the bone and into the blood, so it causes hypercalcemia. So A is definitely wrong. So just to mention the types of plasma cell dyscrasias, there is solitary plasmacytoma, monoclonal gammopathy of undetermined significance, and Waldenstrom macroglobulinemia. Other symptoms that I've not mentioned, there is fever, night sweats, weakness and weight loss. There's also bone pain and spontaneous fractures. Remember that the bone marrow functions are deranged. So when I've also mentioned that there's osteoclastic functions, so definitely the bone integrity is messed up with, so it causes spontaneous fractures. And then I've mentioned leukopenia, thrombocytopenia, and there's also foamy urine as a result of the Bence-Jones proteins in the urine. Next question. The diagnosis of acute leukemia is based on. So it is said that the definitive diagnosis for acute leukemias is based on the blast cells. So the percentage is what you need to pay keen attention to. It's 20% or more blasts in the bone marrow. That's what is used to diagnose acute leukemia. For the baseline investigations, we have the total blood count, where we expect elevated white blood cells because of the leukemia, and there may also be anemia, and thrombocytopenia is also possible, but it's not always there. We also have the peripheral blood film and bone marrow examinations, where when you do the BMAs, you'd find the blast cells, and also when you view under the microscopes for AML specifically, you will see our rods. I hope we all know how that looks like, because it's a very likely spot. Make sure you look into it if you don't. And then there's also genetic tests because of it may be hereditary. And there's also cytochemical staining. What is important is that you know that for AML, it's positive for Sudan black dye, and also it's esterase positive. Make sure you know that. And for all of them, they're PAS positive. So for the next question, we have clinical features of organ or tissue infiltration in acute leukemias include all the following except. So I have a table here that has the general features and the clinical features for the specific ones. So we see that for all general acute leukemias for both ML and ALL, we have anemia, thrombocytopenia, and there's also leukopenia and hepatosplenomegaly. Then for ALL, we have fever, painless lymphadenopathy, bone pain, airway obstruction, meningeal leukemia, leukemic meningitis, this is very important, and we also have testicular enlargements. Then for AML, we have leukemia cutis, which is a condition affecting the skin and it causes skin lesions. And then we have gingival hyperplasia, which may also have signs of CNS involvement, including headaches and visual field changes. So in this question, we've seen that there's testicular enlargement, gum hypertrophy, mediastinal mass, I didn't find that anywhere, and meningeal syndrome, I've talked about the leukemic meningitis. So the answer that was most likely was this one for bone fractures. Someone kindly read the next question. I feel like I'm talking too much. Kindly just unmute and read it out.
The ideal product for a patient who has symptomatic severe anemia is?
So the answer here, thank you. The answer here is packed red cells. This is because packed red cells are used to increase the oxygen carrying capacity of a patient. So packed red cells are used for patients who have thalassemias, sickle cell disease, or what was the other one? Just a second. Severe anemia, yeah. So remember that for all the blood products, you need to know the ideal storage conditions, the lifespan, and the preservatives that are used. So specifically for packed red cells, it is stored, the right temperature for storage is 2 to 8 degrees Celsius, and it lasts 42 days. And the preservative is saline adenine glucose mannitol, SAGEM. So make sure for all the blood products, you know the indications and the necessary storage conditions. Someone please read out the next question.
Why can't we give whole blood, considering the patient is losing basically almost all the cells?
For asymptomatic severe anemia, I think the major problem is iron. So how do you increase the iron so that you can increase the oxygen carrying capacity of that patient, or you work on the red blood cells? If you give other products, let's say white blood cells, it won't, or you asked about whole blood. When you give whole blood, you actually risk having a circulatory overload in a patient. So it's important to also give just what the patient requires. So in this case, packed red blood cells will be able to increase the hemoglobin levels so that the oxygen levels are also increased. Giving other products may be assumed to be a waste, at least that's in my opinion. And that's why different blood products are given for different needs. I don't know if I've answered your question.
Yes, you have.
Okay, thank you. Next question. Complications of long-standing extravascular hemolytic conditions include all the following except. So we know that extravascular hemolytic conditions, it means the red blood cells are degraded so fast. So it means that we'll have a problem with iron deficiency. And also because the blood cells are being degraded so fast, we are likely to have an aplastic crisis, whereby we are lacking cells. We're lacking red blood cells, and therefore we'll be having low levels of HB as well. And also the aplastic crisis calls for increased production of cells by the bone marrow, therefore increased folate utilization and as well as B12 utilization in the process. So it leads to B12 and folate depletion, thereby causing megaloblastic anemia. Then as for hemolysis, hemolysis causes extravascular hemolysis can release a significant amount of hemoglobin from the ruptured red blood cells. Therefore, when the hemoglobin is broken down into heme and globin, with heme further being broken down to biliverdin and bilirubin, there is elevated bilirubin levels, and therefore it causes formation of bilirubin gallstones. Yeah, so I've explained A, B, C, and D. So that leaves us with chronic leg ulcers. While chronic leg ulcers are caused by sickle cell disease, it's not caused by the long-standing extravascular hemolytic aspect of it. So when we're talking about extravascular, we know that it's grouped into intracorpuscular red blood cells defect and the extracorpuscular ones. So remember that the intracorpuscular ones entail the membrane defect, hemoglobin effect, and the enzyme defect. So make sure you can be able to tell the difference, while the acquired ones or the extracorpuscular ones are the ones that are caused by immune causes, like autoimmune hemolytic anemia, or by non-immune causes, for example, malaria. So make sure you have that in mind, and you can also read that in depth. So for the next question, the management of a patient with hereditary spherocytosis includes. So for hereditary spherocytosis, the sole definitive treatment is just splenectomy. So whenever you see management of a patient with HS, just know the answer is splenectomy. Then I also thought it was important to... Yes?
There's a question in the chat box.
Oh, thank you. Let me...
Oh, okay.
Kindly help differentiate intravascular and extravascular hemolysis. So I think I had, just give me a second. I had some slides, but I chose to. Okay, so for extracorpuscular causes, these ones are the ones that happen within the blood vessel. No, outside the blood vessel. And for the intracorpuscular ones, they're the ones that happen within the blood vessels. For example, for membrane defects, these are defects to do with the hemoglobin membrane. So you see, these are things that are happening inside the blood vessels. For example, hereditary spherocytosis. You see that that's a problem with the membrane of the red blood cell where it lacks elasticity. And also something like, what are the ones I've forgotten the other examples? Hereditary spherocytosis. Can you mention others? I've forgotten. No one has anything in mind. Okay, you'll just go and look through them. For the HB defects, the thalassemias, For the enzyme defects, what deficiencies? The G6, is it G6P? Yeah, PNH, that's true. Hereditary elliptocytosis. Yeah, so you see those ones happen within the the blood vessel. When you look at the extracorpuscular ones, like infections, these are not things that are being controlled within the blood vessels. Like this one, you see when malaria, bacterial sepsis, and all these are happening externally, or the toxins or chemicals in drugs, or for the immune-mediated ones like hemolytic transfusion reactions. These are not things that are to do with the blood vessels. They're happening outside. I don't know if I've been able to answer your question.
Yes, thank you.
You're welcome. I've seen there's another question. Can you please explain the megaloblastic one? Where is it? Is this the one you're asking for me to explain D? Okay, so for megaloblastic anemia, this is how it comes about. So we know that folate is required for production, for erythropoiesis, for red cell production. So in a condition where you have extravascular hemolytic anemia, what happens is, let's use, for example, an autoimmune disease. So the antibodies are directed towards the red blood cells. So there's continuous degradation of red blood cells. So how does the body respond to this? When there's continuous degradation of blood cells, then the bone marrow increases its activity in erythropoiesis, like it tries to balance out the loss. So when this happens, you know that folate is used in the process. So more folate is required, and the production is also heightened. So when production outweighs the folate utilization, when the production is higher than the folate that you have in the body, then it means that there'll be a deficiency. So there'll be folate deficiency. And when there's folate deficiency, then it means that you'll develop megaloblastic anemia. When it comes to vitamin B12 deficiency, sometimes some of these conditions, they affect the absorption of B12 from the stomach. So that's how it brings about a deficiency, and it causes megaloblastic anemia. Yeah, I think now we may continue. You're welcome. Question 6. Oh, we've already done that. Question 7. The following statement is true regarding the management of iron deficiency anemia. So the true statement is B, oral iron therapy should continue for 4 to 6 months. Oh, okay. The following statement is true regarding the management of iron deficiency anemia. So it's B, oral iron therapy should continue for 4 to 6 months to replace iron stores. So let's start with E. All microcytic hypochromic anemias respond to iron therapy. So that's not true. Remember that microcytic hypochromic anemias, there's I'm forgetting the right word. It's not a mnemonic. What do you call those things that you list them down like tails? I don't know if you guys know it. So We have thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning, and sideroblastic anemia. So you notice that the only one that is caused by the deficiency of iron is this one, iron deficiency anemia. So for all the other microcytic anemias, they won't respond to iron therapy. For D, where blood transfusion is necessary, whole blood is best. I've just explained before that when you're doing blood transfusion, you have to think about what component does this person need. You can't just give whole blood just because it's there. If someone has leukopenia, you just give white blood cell concentrate. If someone has severe anemia, you give red blood cell concentrates. Yeah, along those lines. So blood transfusion for whole blood is not necessarily the best option for everything. Then for C, parenteral iron is always indicated if the HB is less than 5 grams per deciliter. So it's not 5 grams, it's in fact 10 grams. Then for A, in all cases where the HB does not rise despite iron treatment, it means that diagnosis cannot be iron deficiency. I didn't find anything to do with that, so I can't explain why it's wrong, but I'm sure about B. So the next question is, heparin mode of action is, so heparin, it binds to antithrombin, and it promotes the effect of antithrombin because it increases the interaction of antithrombin with clotting factors. Therefore, it inhibits factors like factor 2, factor 10, factor 9, factor 11, and 12. So remember, it's antithrombin, so it prevents clotting formation. So for the next question, we have question 9. Plasma cells dyscrasias include the following except. I mentioned this on a previous slide. The answer is B, lymphocytic myeloma. We said that there's multiple myeloma, solitary myeloma, monoclonal gammopathies. For the next question, question 10, anemias of chronic disorders are associated with the following features. So for anemias of chronic disorders, remember that it's not that the body lacks iron, it's that the utilization of iron is a problem. So that means that the serum iron is low, but the iron that is stored is actually high. So for A, the serum will be reduced. And then for TIBC, the TIBC will not be raised. It will either be normal or reduced. Then for D, normal or elevated serum ferritin. That is the one that is true. So the serum ferritin will be normal or elevated. Absent bone marrow iron stores, I've said that the problem is not with the storage, it is with the utilization. So E is also wrong. So there's this table over here. If it's hard to cram, you can actually, to understand, you can just cram. I think that's what I did. Yeah, so for iron deficiency, that one, I think that's easier to get because you know that the serum iron is low and the transferrin is increased because of the low iron level. So it's trying to like find extra iron which it can transport. So the transferrin is actually high. Transferrin TBC, sorry. Yeah. There's transferrin saturation and the transferrin TBC ratio. So okay, I think I've confused myself. Let me not use this table. I'll try and look it up and explain it again. Or someone else can do it. Does anyone want to do it? Nobody? Okay, yeah, you'll have to look it up on your own. Sorry. Yeah. Yeah?
I think I can try.
Yeah, please do.
For transfusion, it's the way you've explained. The body is trying to bind more iron, that's why it's high. But transferrin saturation, there's low iron in the body, so there's no way the transport protein for iron is going to be saturated. So that's why the saturation is low, since the iron present is low.
Yeah, yes, that's true. That's true. Thank you. So yeah, just remember, for once you know that the transferrin in iron deficiency is high, then the one for anemia of chronic disease is low. You'll be able to get a hang of it. And then also make sure you read about hemochromatosis. Make sure you read about that. I saw a few questions last time. So for the next question, the following is not true of intrinsic factor. So let's just start with the eliminating. E is true. It is a 44 kilodalton glycoprotein. Then D is also true. Deficiency is usually accompanied by achlorhydria. So when achlorhydria is, that's when someone is constantly vomiting, that's one of the causes of achlorhydria, when there's no chlorine in the body. So yes, they usually accompany each other. Then it binds to vitamin B12. That's true. That's how vitamin B12 is absorbed, by binding to intrinsic factor in the terminal ileum. Then deficiency leads to pernicious anemia. That's true. For A, it stimulates the pancreas to release secretin. So that's not true. It actually inhibits secretin, and it stimulates production of gastric acid. So of importance to note is that intrinsic factor is produced in the gastric parietal cells. And as I've said, it binds to B12 and it enables its absorption in the terminal ileum. It stimulates production of gastrin as well as histamine, and it inhibits production of G1P, prostaglandins, secretin, and somatostatin. For the next question, I'm almost done. I just have like 6 more questions left. ITP. So ITP results from immunologic reactions against the platelets. So antibodies are formed against platelets, and it leads to destruction of thrombocytes, which leads to thrombocytopenia. So what was important to note from the choices is that it's not self-limiting. Treatment is usually done by corticosteroids or IV immunoglobulins, as well as splenectomy for the chronic disease, but also it is self-limiting in children only. Then you can't say that it mostly presents as acute, because 80% of adults present with chronic ITP. So yes, I've already explained. I've done the summary of the pathophysiology, so you can go through it in depth. I know most of you are tired by now. So for question 13, definitive diagnosis of sickle cell anemia is based on. So this is actually a catch, especially in your sports. Make sure you know that for definitive diagnosis of sickle cell anemia is HB electrophoresis. But for all other tests, the ones for the screening test, now that's where you can put your sodium metabosulfite. That's where you can put the one for oxygen concentration, the solubility test, yeah. You can put your HPLCs and your isoelectric focusing, but when the question is definitive diagnosis, the only answer is HB electrophoresis. Make sure you can also read the results for HB electrophoresis so that you can know whether it's a sickle cell trait or a sickle cell disease, or yeah, things like that. Then thrombophilia is associated with all the following except increased levels of plasminogen activator. So when you increase levels of plasminogen activator, plasminogen ensures conversion of fibrin to fibrinogen. So if you increase the levels of plasminogen, then it means that you will actually be increasing, you'll be promoting this process of fibrin degradation. And when you're looking at thrombophilia, it means that there's so the factors that, can you hear me? My laptop is telling me my internet is unstable.
Yes, we can hear.
Thank you. So when you inhibit protein C, protein S, then you're inhibiting this process of clot formation. When you inhibit then factor V Leiden, it causes it is a cause of protein C resistance. So it also affects protein C and protein S. So it also leads to thrombophilia. Then antithrombin deficiency. When there's no antithrombin, definitely there's a lot of clot formation. So yeah, those are the factors affecting that. Then in addition, we have antithrombin 3 deficiency and hyperhomocystinemia and prothrombin mutation. So anything that will affect the formation of the clot. So that's protein C. When it comes to protein C, remember there is deficiency and resistance. And then there's protein S deficiency, and there's antithrombin 3 deficiency and prothrombin mutation, together with hyperhomocystinemia. Then for the next question, the following agent or drug is classified as an oral anticoagulant. Remember, for oral anticoagulants, the only one that is used right now is warfarin. Heparin, high CC oral. Then for question 16, in coagulation testing, the finding of prolonged prothrombin time, APTT, and TT supports a diagnosis of. So remember, this is actually very important, especially for your sports. If you see that the PT, APTT, and TT are elevated, just remember, just think of DIC. That is the first thing that should be coming to your head, because there's a question in the coming slides that asks about the pathophysiology of DIC. Remember, DIC happens, when DIC happens, it causes all the clotting factors to be depleted because it involves everything. So all the pathways will be interrupted. So the PT will be elevated, APTT will be elevated, as well as TT. So remember that thrombin time tests for the integrity of the common pathway, while prothrombin time tests for the integrity of the extrinsic pathway. So remember, for prothrombin time, we usually say play tennis outside. So play tennis, extrinsic like external, whatever, outside. So prothrombin time is for extrinsic pathway. Then APTT is for intrinsic pathway. Then the bleeding time, it tests for the primary plug. The formation of the primary plug usually involves platelets and von Willebrand factor. So in this table, we have VWF, von Willebrand factor. We've said that von Willebrand factor is involved in the bleeding time, so that is elevated. And also the APTT will be elevated because of, we said APTT is for intrinsic. So it will also be elevated because of factor 8. VWF is usually carried together with factor 8. So factor 8 is involved in the intrinsic pathway. So that's why it has an elevated bleeding time and an elevated APTT. For classic hemophilia is deficiency in factor 8. So as I've just said, factor 8 is involved in the intrinsic pathway. So bleeding time will be normal, prothrombin time will be normal, and the APTT will be elevated. Then factor 9 deficiency, bleeding time is normal, prothrombin time is normal, and we say factor 9 is also in the intrinsic pathway. So APTT will be normal. So remember to note that for classic hemophilia and factor 10 deficiency, that there is no difference. They'll bring you the questions to trick you, and you'd probably write maybe factor 9 is in another pathway, no. But in reality, both of them affect only APTT. So remember, for when TT, PT, and APTT are elevated, BSc. When it's bleeding time and APTT, BWF. When it's APTT only, it's hemophilia, either hemophilia A or B. So, for the next question, I think this should be the last one. Yeah, the second last. So, which of the following contains or are erythrocytic inclusions of RNA and can be observed by staining with new methylene blue? So that will be reticulocytes. Make sure you know all these bodies. Hizo nye zinakuanga uko kwa hemat somewhere. There's a lot of bodies. Make sure you know each one of them. I won't go through them. But of importance is Haynes and Howell-Jolly. Make sure you know those ones especially. Next question, which is the last one. The pathophysiology in DIC is, so I mentioned this before. The answer is A. It causes a widespread fibrin deposition in microvasculature with the consumption of the coagulation factors and fibrinolysis. So in the long run, this person can't clot because the coagulation factors are all depleted. So it's actually a very life-threatening conditions. You can check there are conditions that predispose, not conditions like, for example, surgeries, pregnancies. Make sure you look into those. There are things that will predispose one to having DIC. So make sure you have a look at that and you read it in depth. Are there any questions?
The table on classical hemophilia, kindly.
This one.
No? Yeah, that
This
one.
one. Mm-hmm. You would like me to explain it again?
No, thanks. It's okay.
Sawa.
Mhm.
Haya. If there are no any questions, we'd like to end it here. And also, let me ask, let me look at the chat box. You're welcome. Is there anything that you'd like to go through in specific before you do your exams?